Hello, my name is Hitesh Patel. I'm a cardiology research fellow from the Royal Brompton Hospital in London, and today I'm going to talk to you about renal denervation and new exciting prospects for it on the horizon. My disclosures are that I'm funded by the NIHR BRU at the Royal Brompton Hospital. So in terms of today's talk, I'm going to go over how renal denervation works, in particular with respect to hypertension, but also by looking at its mechanisms of action, how it could be used for other diseases in the cardiac arena. We're also going to talk briefly about a trial that I've started at the Royal Brompton Hospital with my supervisors and how we're using imaging techniques for this. So firstly, sympathetic nervous system and hypertension. It's been known for many years from both animal work and from clinical trials that the sympathetic nervous system is grossly elevated in resistant hypertension, and reducing this sympathetic overactivity does improve outcomes and does improve blood pressure. This was actually shown first surgically in the 1920s when surgical sympathectomy was the only treatment available for malignant hypertension. It wasn't until the 1950s when oral antihypertensive agents became available that this surgical practice was discarded or put in the back burners. And we can see why on the next slide here, that when the surgical procedure was performed, not only the renal nerves were cut, but also the abdominal nerves, and that of course caused a lot of side effects. So now over the last 6 years, for the first time, we have a minimally invasive procedure that can now be used to denervate the renal sympathetic nerves specifically. And by looking at this diagram, you can see that the sympathetic nerves run in close proximity to the renal artery, and that makes it very amenable to radiofrequency ablation. In fact, 90% of these nerves lie within 4 millimeters of the renal artery wall. So why are we interested in particular in the renal sympathetic nerves when it comes to cardiac disease? Well, to answer this diagram nicely summarizes the key factors. Firstly, we have to look at the efferent nerve supply, and then secondly, the afferent nerve supply and the mechanisms of action that these nerves have. So starting with the efferent nerves, these are the nerves which come from the brainstem and run directly to the kidneys. When the brainstem activates the sympathetic nervous system and these signals are sent to the kidneys, this causes salt and water retention at the kidney level, causes renal vasoconstriction and reduces renal blood flow, and also importantly activates the renin-angiotensin-aldosterone system. But similarly, the kidney is not passive in this. It also sends sensory signals back to the brain via the afferent nervous system. And it usually sends signals back when it has ischemia or some form of infarction. But also other factors such as acidosis increases the afferent activity. Now, when these afferent nerves synapse in the brainstem, the brain not only sends more sympathetic nervous system signals to the kidneys, but also to other key organs in the cardiovascular disease spectrum, notably the heart and the peripheral vasculature. And this is very interesting because elevated sympathetic nervous system to the heart causes not only hypertrophy, but promotes ischemia as well. And in the peripheral vasculature, this will cause poor endothelial function and thickening of the peripheral vasculature. All of these factors are very important in the management of hypertension. But also, now thinking of other diseases in which salt and water retention is important, we come to heart failure. Now, in heart failure, the sympathetic nerves are actually elevated greater than it is in hypertension, and also the outcomes in heart failure are much worse than they are in hypertension. So if ever there was a use for this new procedure of renal denervation, it would be more in the heart failure population, though it is still very effective in the resistant hypertensive population. So bearing that in mind, at the Royal Brompton Hospital, we've started the RDT Peff trial, which is a randomized control trial with 2-to-1 randomization in which we're targeting 60 patients with heart failure with preserved ejection fraction and offering them the renal denervation therapy. We have a good basic science background as to why this ought to work, in that renal denervation will reduce the neurohormonal activation in heart failure, it improves the structural remodeling, endothelial function, and the salt and water retention that is key to HF-Peff. But why HF-Peff rather than any other form of heart failure? Well, here is the ESC guidelines from 2012, and I'd like to draw your attention to the first line, which says that no treatment has yet been shown convincingly to reduce morbidity and mortality in HFpEF. So this is a cohort of patients who currently have no known treatment. There are a few cynics out there who don't believe HFpEF exists, who believe that these are just patients who have a normal ejection fraction and actually have some other pathology causing their shorter breath, such as COPD. But this slide shows all of the mortality and hospitalizations over a whole host of cardiovascular trials. And what we have are, in the green, the 3 HFpEF trials, and the rest are all the hypertension trials. And you can clearly see mortality in the HFpEF trials has been much greater than any of the hypertension trials, and similarly for hospitalizations. So now that we've shown that this population deserves attention and hopefully this new therapy will work for it, how do we diagnose HFpEF? Now this is a new criteria that's been published by the ESC this year, and the first 2 are clinical criteria, as you can see, which says that symptoms and signs of heart failure have to be present, but number 3 and number 4 are very much imaging-based criteria, in which a normal ejection fraction has to be shown and also relevant structural changes. So for our study, we've used imaging in 3 main branches. Firstly, in the diagnosis of HFpEF, we've looked for structural remodeling and diastolic dysfunction. Secondly, to look for evidence of the raised sympathetic nervous system. And thirdly, to image the renal arteries and to see what effect this procedure has had on perfusion, which is relatively a novel concept. So firstly, with diagnosis, I'm going to show you a series of images that we have for some of the patients we've already recruited. So if we look at this chest X-ray, even the hardened cynic wouldn't say that this patient does not have the heart failure syndrome. It shows clearly that there's cardiomegaly, that there's pulmonary venous congestion, and that there is evidence of a right pleural effusion. Now, when we look at the echo for this patient, the ejection fraction, as shown in this 4-chamber and 2-chamber view, are clearly normal, greater than 50%, but there's also evidence of left ventricular hypertrophy and LA dilatation. Now, if we go to the next slide, we will see that the LA is dilated by BSC criteria by using the biplane measurements that we have here, and it comes currently under the mildly dilated for this patient. Now, gold standard for LV assessments and volume assessments has currently been said that it's MRI. So we've also performing cardiac MRI on all our patients. And as you can see from this image, the resolution is a lot better, and you can clearly see that there is left ventricular hypertrophy. And when the area of the left atrium is traced, it is mildly dilated. You can also see that there are pleural effusions in this patient. But where echocardiography comes onto its own is in the assessment of diastolic function, which is probably the gold standard currently in a non-invasive arena. So this patient has evidence of EA-way reversal, and if we also look at the tissue Doppler images, there is evidence of elevated LV filling pressure with the E to E prime septum greater than 15 and an E to E prime lateral greater than 10. The estimated wedge pressure in this patient is 19 millimeters of mercury from this echo. The other thing we're of course interested in is the renal denervation affects the sympathetic nervous system. We want to be able to show that we have reduced the sympathetic nervous system at elevation. So how do we do that using imaging? Well, first of all, measuring the sympathetic nervous system is not easy. It's very difficult, and currently there are 4 main ways of doing it. 2 of them are invasive, that is noradrenaline spillover and microneurography, and 2 of them are non-invasive, using heart rate variability and radionuclide imaging. The invasive ones require quite specialist equipment and is not widely available in all centres. Heart rate variability, though widely available for use of 24-hour ECG holters, is limited in heart failure, as you cannot use this technique in patients who have pacemakers or have atrial fibrillation, which is quite a large proportion of all heart failure patients. So that leaves us to imaging, and currently we have radiotracers which mimic noradrenaline, which is the key neurotransmitter of the sympathetic nervous system, and we can either use PET or we can use a gamma camera that are found in most nuclear departments. The difficulty with PET is, once again, it's not widely available, and the radiotracers are expensive and require an on-site cyclotron machine. So for our study, we've actually used a gamma camera and a radiotracer known as MIBG, or meta-iodobenzyl guanidine. Now, this substance is a noradrenaline analog, and as I've already said, noradrenaline is the key neurotransmitter of the sympathetic nervous system. So by using a radio-labeled analog, we can identify where the sympathetic nerves are and what the distribution is. The radiation dose from a MIBG scan is approximately 5 millisieverts. So these are some images from some of my patients, but before I talk through them, the patient comes in the morning, they're given tablets of iodine to protect their thyroid, and 30 minutes later they are injected for a peripheral intravenous cannula with MIBG. They then have an early scan, and 4 hours later they have a repeat late scan. So in the image on the left-hand side of the screen, what you'll see is that there's radiotracer uptake starting from the top in the salivary glands, the thyroid glands, the lungs, the heart, and the liver, as you can clearly see. Now, all of these organs have rich sympathetic innervations. Now, if you look on the later image, 4 hours later on the right side, you can see that some of this radiotracer uptake has reduced, and notably in the heart. Now, when you have to quantify this, there is a technique called heart to mediastinum ratio, where pixel counts are performed in the mediastinum, where there should be no radiotracer uptake, and pixel counts are performed on the myocardium. When this is reduced, it confers that there is sympathetic denervation. Similarly, another measure called a washout ratio compares how fast the loss of tracer is seen between the early and late pictures. Another scan that's possible as a part of the MIBG is SPECT images can also be taken, and most cardiologists will be familiar from this from ischemia testing. Now, looking at this polar map, the most apparent abnormality that can be seen is the large purple area in the inferior territory, which suggests that there is regional sympathetic denervation in the heart, which is very interesting from the research point of view, as this may be implicated in arrhythmias in our heart failure patients. The other cause of this loss of sympathetic nerves in the inferior territory would be a myocardial infarct, but as we've already seen from the MRI in the previous slides, that this patient does not have any regional wall motion abnormality or evidence of late gadolinium enhancement in that area. So moving away from imaging the sympathetic nervous system in heart failure, the final part of imaging in our study is we need to show that it is feasible and safe to perform renal denervation in our patients. One way of imaging the renal arteries directly is by performing a magnetic resonance angiography of the renal arteries, and this MIP picture shows it clearly. If you look on the right, at the right kidney, you'll also notice that this patient has dual arterial supply to the right kidney, and there's a small artery at the base of it. One other aspect we are now developing at the Brompton is we're assessing perfusion through the artery to the kidneys to see if before or after renal denervation we do in fact increase perfusion to the kidney. So these are actually the results of scans which I've performed on myself, as we don't have patient scans available at present. But what you see are very good traces of renal blood flow in both the right and the left kidney, and I've performed the assessments on 2 separate days to show how very reproducible the figures are. And what you can interestingly see is that the flow never drops to 0, which is what you would hope, as there should always be diastolic blood flow to the kidneys throughout the cardiac cycle. Now, what does this mean for the future with renal denervation? And we've shown and discussed that the sympathetic nervous system is abnormally activated in various cardiovascular conditions. And currently, what we have evidence for is that renal denervation works in resistant hypertension. On average, it drops the blood pressure on a 24-hour ambulatory monitor by 10/5 millimeters of mercury, which is actually better than most oral antihypertensives. There are currently ongoing trials in other indications, notably heart failure, obstructive sleep apnea, renal failure, arrhythmias and metabolic syndrome. However, renal denervation is not the only therapy that's currently available to target the autonomic nervous systems. There are now 3 other devices which are at various stages in clinical trials which have been evaluated in cardiovascular trials. And these include baroreceptor stimulators, as shown on this diagram, vagal nerve stimulators and spinal cord stimulators. So the future is going to be very interesting, and we hope that we are able to provide more for our patients, especially with heart failure with preserved ejection fraction, which currently has no treatment. Thank you very much for listening.